Hello, everyone. Welcome back. I hope your breakout sessions were helpful and productive. We're now moving on to a really crucial part of the conference, in many ways, the most crucial part of the conference, and that's a summary of the key outcomes of our 4 days together. We've had such a rich and diverse range of perspectives and expertise from all of you since Monday, and I'd like to take this opportunity to thank you all so much for your critical engagement throughout that time. And I am just delighted now to introduce and welcome Kate Golden. Kate is Concern's Senior Nutrition Advisor, and she's going to guide us through this session. She's been working in nutrition programming and response for more than 15 years. Her career started in Ethiopia in 2003 on one of the early study pilots of community-based management of acute malnutrition. And since then, she's worked across 20 countries in South Sudan, Lebanon, supporting Concern's nutrition program and strategy development, both in Africa and Asia as a global advisor. So as I say, I'm delighted now to hand it over to Kate.
Thanks, Ella. Hello, everyone. Great to sort of see you all. And I'd just like to start my presentation. Just let me know if anyone cannot see my presentation, just drop it in the chat there. Just with a short, sweet, mega thank you to everybody who has endured through these 4 days, who's put up with the technical glitches, and has just been incredible with discussions, facilitation, presentations, etc. So thank you, and I hope you'll stick with us just for another hour or so. So I have what seems like an incredible task to try to provide a summary of workshop outcomes so far. And I'm saying so far because we still have a very important session next with a number of esteemed policymakers and decision makers. So I will take you up to where we are at the moment. Okay, so going back to what the conference set out to do, we very much anticipated or attempted to focus on the scale up of services for the management of wasting in fragile contexts. And we aimed to identify and agree key barriers and enablers to scaling up, list practical considerations for scaling up new adaptations, and priority actions to address barriers to scale up, and finally advocacy priorities and upcoming opportunities to support scale up. I'm going to focus on the first 3 because, as I said, the next session will hopefully get into the 4th objective there. So going back to a slide that Ella had on day 1, following on from our presentations from a number of people at global level, country level, and experts in the field about where we are now. And looking at this slide now on day 4, I think the themes that were captured here with just a few additions really still are relevant and reflect very much the discussions that have happened since. So the first is around the CMAM promise that Saul Guerrero mentioned and kind of hooked us all in, and I think it resonates with us, that 20 years ago CMAM promised access, scale, and coverage, and that we have not necessarily delivered on that promise just yet. Coverage we know is still far too low, and community, the community aspect, the C in CMAM, feels a bit missing at times and something that we need to get back to. And there's a risk that the medical and technical issues that we often focus on may be eclipsing some of that community engagement. We also need to continue to simplify. This is absolutely necessary if we're going to go to scale. And we need to remember that the ideal or the perfect is often the enemy of the good. We need to reduce our UTF cost, as was discussed a lot on day 1 and continues to come up in country presentations and even in presentations on the adaptations themselves. And in terms of the adaptations, we have seen throughout throughout the last few days that many are well advanced, and just a very crude assessment is that family MUAC seems very much ready to go, and that the others we've looked at have huge potential for coverage, but there may be some more implications that we need to consider, whether costs or human resources, and some may need more operational piloting before they can go to scale. The role of the government was very much clear from our country case studies, and their role is to harmonize approaches and evidence that are often brought in through diverse NGOs, and to turn that into a national policy and prioritize where resources are going to go, and to take ownership. And Amina Abdullah, the country director of Concern Kenya, made the point this also means that country governments need to allocate some of their own resources to make this happen. Prevention of malnutrition was a huge preoccupation with all of us and remains one. And I think, as Emily said in her presentation, prevention is obviously the most cost-effective and humane way to address malnutrition. It's essential to stem the flow of new cases of wasting, but unfortunately, we know that treatment is still needed and that we need an integrated package of nutrition interventions to deliver and achieve both. COVID has spurred adaptation and innovation. There's still a question of what next if we do, in fact, get past COVID. And financing, last and foremost, is we need more funds, we need more efficiency, and we need to focus on what is mission critical. So, looking briefly at the progress on scale up, just paraphrasing what has come through in a number of presentations, our coverage has improved tenfold, a tenfold increase since 2000 when CMAM first started to be piloted, but we know that roughly 80% of wasted children are still not reached, and 70 countries now have CMAM in their national policies, but many barriers remain to policies, putting policies into practice and integrating wasting treatment into routine health services. And stealing a slide from Saul on the right there just shows that even over the last 8 years, we have doubled the number of children who have been treated. So looking then at our 6 case studies and looking particularly at the burden of wasting, the prevalence of wasting, this is again a very rough assessment eyeball of the trends that were presented in the case studies and the presentations. And it shows a mixed picture. I think from Ethiopia, you can see a declining trend in wasting, maybe not as dramatic as we'd hope, but it looks to be going down. But when I look at Somalia, Kenya, Niger, South Sudan, and Pakistan, what I see is ups and downs, and I think we have to be vigilant and prepared to be dealing with these spikes, whether they're between years or even seasonal spikes. We need to be ready with the resources and the plan to address them. But we are treating more children. You can see in the graph there at the top that Ethiopia has increased the number of health facilities that have services for severe wasting between 2003 and 2017, a dramatic increase over that time. And South Sudan as well has nearly doubled the number of SAM admissions in the last 6 years. So progress is being made. But there are still barriers. And what I heard over the week are a number of barriers, and these are the ones that I've pulled out. Obviously, there are many more, and I encourage you to read the ENN report and to explore the presentations from the week in your own time. But these were the key ones that I heard. Finance being absolutely one of the biggest. So there are not enough funds, especially for the moderate caseloads. And often we still rely on short-term emergency funds or funding via NGOs. It's complex, it's not sustainable. And there's a question about how big the pot is and how much more can we ask for. We do need to get more efficient in how we're delivering these programs, but we probably need to keep asking for more and keep wasting on the agenda. Supply chains, they seem to be better where UNICEF and WFP are supporting heavily, but again, that's not sustainable. The cost of RUTF, the delivery of RUTF. And then an issue that was raised in a number of the case studies is just the limited service reach in the vast, difficult, and often insecure terrains that they're trying to cover. Community health workers are core to so many of the adaptations we've seen and to CMAM itself, but they're often not formalized, they're overburdened, they need a living wage, and a sustainable funding strategy and policy needs to be put in place in countries where we're depending on them. And the health facility workforce as well are often overburdened, especially in the hardest to reach areas where the caseloads might be highest, and no coordinated pre-service training on severe wasting is present in many countries. We asked a question on day one via Mentimeter, asking where you think the biggest barriers to scaling up services for the management of severe wasting still exist in fragile contexts. And we were surprised to see that policies came up the highest, but actually we asked on the second day, we asked a follow-up question about whether these were the policies themselves or the implementation. And the vast majority of those who responded said, no, it's actually the implementation of policy. So it seems that the policies are there, but again, trying to turn that into practical action is proving challenging. So the enablers in brief, this is a hybrid of some of the points raised in the ENN report based on stakeholders, consultations with stakeholders, and drawing from the case studies. So I'm not going to go through in a lot of detail here, but just to say under leadership and government, key issues were around the positioning of severe wasting within national and subnational agendas and policies. And we saw a number of examples from the case studies where this has been at least partially addressed, and we have best practice that we can draw from. We need to ensure that maternal and child health departments are owning wasting services so that they see the value of integrating them. And we need stronger coordination at national and subnational level. The health workforce, again, these are along the building blocks, the health system building blocks. The key enablers around health workforce, a key one is around community health workers. So making sure they're adequately budgeted for, appropriately valued and remunerated, and functioning, and they have a functioning referral system that they can send children to health facilities and they can be sent back for follow-up. We need to integrate severe wasting into community health platforms. We had a good example from Niger where they integrated the MUAC screening into annual national malaria campaigns and got huge numbers of screening in return. We need to anticipate fluctuating caseloads throughout the year and include wasting data into existing health information systems. And finally, financing and supplies. And unfortunately, we don't have a lot of best practice to draw on from the case studies. Accurate forecasting was mentioned in the ENN report as being central to ensuring the activities can be funded. And this is important at the national and the subnational costing, national and subnational level. We need to look for longer term funding and innovative financing. And I've put a question mark, because I hope that this is something that the next panel can be thinking about today and as we move forward, because these are really macro level financing opportunities and strategies that need to be invested in. And then, as we know, for supplies, we have agreed that we need new RUTF recipes, we need more local production, and we need to include RUTF in essential medicines list, though many of the governments that have presented here have already done that. Moving into adaptations and practical considerations and readiness for scale. I have taken the liberty of doing a bit of a traffic light coloring there to ensure that we, just to give you a very crude assessment of which ones may be ready to go to scale, but we had an excellent working group session just now. So we have family MUAC, which seems very ready. We have CHWs treating wasting, which was been piloted on a modest scale. It may have some more implications that we need to consider. And then the simplified nutrition protocols has huge potential, but they will likely require some kind of WHO endorsement for scale in some countries, and they need more robust cost projections with extra, considering the extra moderate cases. CMAM Surge, we think, has good potential. It's expanding now, and we're trying to learn as we go. And MAMI, I think, by the expert group's own assessment, needs a bit more time. It has an excellent set of integrated tools, and it's operationalizing and further testing some of those tools now. In the interest of time, I'm going to skip here, but just to say that the potential for these these adaptations have been extremely, have been a lot of expectation, and there's been a lot of support there that these can actually go to scale and have huge impact. On the integration of severe wasting in health systems, we believe it's critical for scale, strengthen health systems first, and that's needed most everywhere, and strengthen community health platforms, and then push for some of the treatment to the community. These are important strategies. And on the issue of MAM, how will we bring these to scale? There was a lot of discussion about needing alternatives where there is no WFP or specialized nutritious food, alternatives based on local foods, and the simplified nutrition protocols offer huge potential. But the question is, who will pay for the moderate caseload treatment? And coming now to the priority actions. Again, this will come to you in the final report, and we will hopefully have some kind of interactive ranking exercise afterwards. It's quite difficult to summarize everything, particularly as we just had the expert working groups just finished about 20 minutes ago. But around RUTF, again, looking at unlocking the global competition and local production and finance. Hopefully, these macro level financial strategies can be looked at in the next session. CHWs, again, as we've already stated, need to be supported. And finally, adaptations and simplified approaches. We hope that these will be brought into discussions at national policy level, that WHO will include as many in the evidence review for upcoming global wasting guidelines. And we need new tools to project the possible increase in caseloads, including the moderates, particularly in the simplified approaches. And again, these will come to you in the report based on the group work around the specific adaptations. So finally, the next steps, the conference outputs and follow-up. We will have the pathways to scale papers for each of the adaptations and the conference report to you by the end of April. And then we hope to have follow-up engagement in the coming months, particularly around RUTF cost and supply chain, putting the community back in CMAM, and around the food systems summit. There are a lot of discussions around game changers, and Connell hopes to convene a dialogue on wiping out wasting. And there are many technical coordination bodies that are looking at each of these adaptations, and we will continue to engage in those. So I think I am nearly out of time. And we have an evaluation for the whole conference, which I think Sinead will drop into the chat shortly. And this is the graphic harvesting, summarizing some of the key themes that we've discussed this week. So I will leave that there, and I will give you a moment to look at the conference evaluation. Thank you. I'm going to stop, and I hope to see you in the next session.